Today's Thanks, Joe. Today is July 15th. It's 9:01, and this is the Incarceration Prevention and Reduction Task Force Behavioral Health Committee meeting, and we've got about a dozen folks on the call today. Jill, do you want to just like scroll down so I can see the land acknowledgement? Okay, let me do this real quick. Okay, so before we begin, we acknowledge that we're gathered on the traditional and unceded territory of Lemhi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land for since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what's been buried by honoring the truth. We pay respect to elders past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. So I'm going to call us to order here, and we're just going to rearrange the order of the agenda so we can get Mike Hilly to present on OD stats because he's got to take off here in a half an hour, and then we're just going to go through the rest of the agenda. So go ahead, Mike. The floor is yours.
Yeah, thanks, Dan. I appreciate it. Once again, I apologize for having to leave early. Just conflicting meetings today. So I'll share my screen real quick. I know most people have been familiar looking at this data, but this is our monthly overdose data at this top screen here, going back to the 12th. So that was on Saturday. And what's been curious about this you can see over the given months throughout the years that we have these sudden spikes in a day. So what I know is that on Saturday, they had a little bit, probably a couple of non-opioid overdoses. This might have been alcohol, meth, or something like that. But we have these spikes that tend to pop up. I know on Sunday and Monday, I believe Sunday, there were 2 overdoses and then one just yesterday. Our data dashboard hasn't caught up. But this curiosity has also got the attention of the sheriff and the medical examiner just to see if there's any correlation to anything here. I don't know if this is one day you get a batch of bad drugs, or it's just one day that it was just unlucky for everybody, or more drugs on the street. And are these clusters, are these amounts happening in the same place? So we're kind of looking at that. I just find it interesting that we have this sudden spike in a given day, but then the next 2 days it's only 1 or 0. So look at this is our monthly overdose count here. And we'll say that we're sort of staying a little bit in a steady area just over the given last 4 or 5 months in about that 130 range, if you will, 100, 130, and 80 and 90. So not a terrible bump up. Once again, looking back to last year, though, that May year was super high, or that month was super high. This is our year-over-year count, and we're tracking here just steady as we get in about halfway through the year, and it's kind of equal with 22 as I look at that too in that given total year at that same time. So, and then this just is an overview of the demographics, male versus female, and once again a different way to look at how many overdoses were given in the months per year. And that's once again the demographics there. And our prior to arrival Narcan is super important. It's been sitting at about 61%. That means that 61, I'm sorry, this is the graph here, 61% of the people survived their overdose prior to EMS getting on scene. That's prior to arrival medications distributed. So we've saturated the county with Narcan. We continue to do that, and it's absolutely saving lives out there. So, and then here's another look at the demographics in the county. So emergency department visits, I grabbed this off the Whatcom Overdose Prevention.org, and these are a number of visits. This is the bottom line is the opioid, and the top line is all overdoses that come in. Remembering that alcohol is a large amount of overdoses that happen in the community as well. So, and then I wanted to point out, I received a really great presentation from the state back in July. Dana Drummond, who is also an epidemiologist and data analyst down there at the state. Let me pull that slide up real quick. I won't present the entire slideshow, but I think it's very interesting to go through that slideshow because it gives a state perspective on how the counties compare against each other and the types of overdoses from a statewide perspective. where all the county health departments contributed at. I thought this was interesting for Whatcom County. This dark sort of blue, if you will, is the state adjusted rate for 34, or the state adjusted rate is at 34.6 per 100,000. And so you can see Whatcom County is sitting up in that higher range on those per 100,000 overdoses in here. So this is how we're comparing against other counties out there. So I just thought this was probably the most interesting slide to look at as we, try to figure out if we're making a dent in the opioid problem here or how we compare with other counties. I'll shift back up to the top of this slide deck though, and you can see there's a lot of data in here. And once again, from the epidemiology section at the state DOH. So I'll just kind of go through. Please take a look at this. This also divides up the different types of drugs that are killing people out there. We still have problems with cocaine and psychostimulants, synthetic, and heroin is still out there as well. So a little bit of a breakdown in the state on what those look like. So anyway, just for the sake of time here, I just wanted to let you know where this information comes from. And also for the chair, if at some time you'd like to get a presentation from state DOH for what's going on statewide, Dana Drummond's been really good at this data, and we usually hear it quarterly at our state Department of Health Emergency Medical Services meetings as we discuss this at the state level with the MPD. So anyway, I'm just glad to share that. Also in the package, I included the monthly overdose surveillance report that's produced by King County, and that gives a little bit more of a regional look at what's going on out there as far as deaths and what's killing people. And those are reports that come after toxicology and after investigation has leaned to specifically what those overdoses were. So I think that's about it, unless there's any questions.
Yeah, any questions for Mike Hilly from EMS? Asha, go ahead.
I like that state one. Did that get sent to us, or is it somewhere a link? Can we get sent the link so I can see it more, look through it more versus rushing?
Absolutely. If you would put your email in the chat, I could do that. And also, Jill did include this on the package that went out earlier. I think it went out maybe last Wednesday or Thursday. But I'll be if you'll just send your email, I'll be glad to send it straight to you.
Okay. Thanks, Mike. Yeah, if you could, just get that over to Tasha, that'd be great. And if anyone else wants to get that information, just let us know. We can do that. Okay. Anything else for Mike Hilly on the stats? Okay. Seeing none, let's move on here. Brian, do you want to introduce your guest speakers?
Okay. Thanks, Dan. I wanted the committee to hear this report entitled Jail Health, Behavioral Health Medications Reach Many Patients, but gaps remain for some. And as some of you know, I worked in the King County Auditor's Office from 2008 to 2014. I didn't get a chance to work with Elise Garvey on a project, but she was there for a few years right before I left. But anyway, I think this report is relevant in the sense that Whatcom County, obviously has a similar system. I believe the staff at the King County Jail, Jill, are those King County employees that work in that unit? So that is one kind of major difference with Whatcom County. But anyway, Elise is going to take us through this report. And I'll turn it over to Elise. Thank you for being here.
Great. Thank you for having us. I'm actually going to have Basil start off for us, who was the other lead on this project. And so he'll go through kind of the first half of the presentation, and then I'll jump in, and then we'll have time for questions.
Can everyone see that? I'm going to assume. Okay. All right. Well, thank you for having us. My name is Basil Hariri. I'm with the King County Auditor's Office, and just wanted to thank you all for having us to share our audit findings with you. So this audit focused on behavioral health services for adult inmates housed in King County's downtown jail, which is also known as the King County Correctional Facility. Behavioral health services include both psychiatric and substance use care and are provided in-house at the jail by Public Health of Seattle and King County. Throughout our presentation, we'll refer to them as jail health or jail health services, and we'll refer to the adult inmates at the jail as patients. So we generally found that jail health services treats patients with acute symptoms quickly within 24 hours, but those with less obvious symptoms can wait a month or more and are often released before seeing a provider. And very few people are receiving medications as they're released from the jail. So today we'll share a portion of our findings and we'll focus on three main parts. The first being how long it takes for patients to receive psychiatric medications. The second being psychiatric medication changes at the jail. And the third being whether or not patients receive sufficient medications at release. So in the report, we make 12 recommendations, all of which the agency agreed with. And today, Elise and I from the auditor's office will be presenting this report. Mia Neidhart and Kimber Waltmanson were both part of this project as well. So with that, we'll go ahead and jump in. So before diving into the findings, I want to provide a little bit of context and an acknowledgement of the work that Jail Health does. So first, Jail Health employs county staff, psychiatric providers, meaning physicians and nurse practitioners who prescribe medications, psychiatric evaluation specialists, and then nurses and a social services team to provide behavioral health medication and services at the downtown jail. This is an especially complicated operation because the jail is a secure environment run by a different agency. So jail health staff work closely with and depend on the Department of Adult and Juvenile Detention, DAJD, to provide healthcare to patients. So this collaboration requires extensive communication, which can complicate otherwise simple healthcare interactions. For example, if there are no correctional officers available to escort a patient to their next appointment, jail health providers have to adapt as best they can. So much more complicated than just a regular appointment, as you can imagine. Next, patients at the jail have higher rates of behavioral health need than the population as a whole. Shortages in behavioral health care in the community mean that many of jail health's patients don't have access to behavioral health care outside of the jail. So a lot of jail health patients do not receive this care anywhere else. Jail health prioritizes stabilizing people who come into the jail with highest and high behavioral health needs, which is a reasonable approach, but can leave some gaps for patients with lower or less visible needs. Despite these complications, jail health provides behavioral health services to thousands of patients every year. In 2023, jail health ordered behavioral health medications for over 2,500 patients at the downtown jail. This audit focuses on those medications, again, including psychiatric and substance use disorder medication like Suboxone. Jail health services staff do provide other behavioral health services to patients like assessments and education, but those were outside of the scope of this audit. We also wanted to note that many people we interviewed had positive things to say about the behavioral health care at the jail. Patients said that it's really helpful for their mental health when they're able to get newer medications. Experts we worked with to review jail health's policies were impressed with the thoughtful consideration put into those policies. And community organizations told us that jail health's practices have improved in recent years, especially around increased access to substance use disorder medications. So lots of good stuff, but the findings and recommendations we described next are meant to help ensure that jail health improves medication access and transparency and builds on work they're already doing. So the key takeaways of the audit, which I kind of previewed before. So the first one is that we found that wait times for clinic appointments with psychiatric providers, which are key to getting restarted or started on medications, can be quite long. Many of these appointments are not completed before a patient is released from the jail. Second, jail health staff members, community advocates, and patients said that some of the medication changes or discontinuations that jail health makes according to its prescribing guidelines can result in negative side effects. There are also opportunities for improved communication with patients about these changes. And then lastly, Jail Health provided a supply of behavioral health medication at release to approximately 20% of people with a prescription for those medications in the jail in 2023. Jail Health is already considering efforts to increase this supply in the future, both in quantity and the number of people that get it. But there are opportunities to reduce barriers for patients now. So the first area we looked at was how long it took for patients to get their first behavioral health medication after booking and entering the jail. And we found that wait times for psychiatric clinic appointments may be a barrier for some patients. We analyzed Jail Health data from 2023 and found that Jail Health ordered most behavioral health medications within 2 days of a patient's booking, and most patients received their medication within 24 hours of Jail Health placing the order. However, we also found that some medications were ordered more than a month after booking. Many factors can affect when Jail Health places a medication order, but some patients can't have their medications ordered until they've been seen at a psychiatric clinic appointment. Psychiatric clinic appointments are where the provider meets with the patient, assesses their behavioral health needs, and prescribes or adjusts medications as needed. The clinic appointments are specifically for patients with lower behavioral health needs who stay in general population housing as opposed to more psychiatric or more intensive psychiatric housing. Folks in psychiatric housing get a different track of appointments that have a shorter wait time. So Jail Health aims to see patients in the psychiatric clinic appointments within 30 days of the appointment being ordered, but has struggled to meet that goal. And something worth noting is that most patients are released within 20-ish days of booking. So definitely within 30 days of booking. With that in mind, let's take a slightly deeper dive into those wait times. So this graphic shows the end result of patients' first psychiatric clinic appointment ordered in 2023. So in the blue slice, you can see that 60% of a patient's order or an order for a psychiatric clinic for a patient was not completed before the patient was released. These are situations where the patient stayed at and left the jail without seeing a psychiatric provider for their needs. In the orange slice, you can see that 22% of appointments were completed, and then the remainder is appointments that were canceled for some other reason. So of the completed 22% of appointments, that orange slice there, you'll see that we found that about 34% were completed within Jail Health's 30-day goal, and most were completed within 60 days. So again, there are multiple reasons for these results, including that stays in the jail are frequently very short, but clinic appointments are a necessary step for some general population patients to be assessed and have those medications restarted or prescribed for the first time. So patients, nurses, advocates, and others we spoke with told us that wait times for appointments were leading to worsening symptoms and behavioral challenges for patients. And Jail Health has taken some steps to reduce these wait times, but it doesn't have a formal understanding of its psychiatric care capacity or the patient need, the overall body of patient need. Jail Health's monitoring of psychiatric clinic wait times is ad hoc and irregular. So given the multiple potential reasons for unfulfilled appointments and long wait times, Jail Health needs to develop additional strategies to reduce wait times suited to its context, which again is quite complicated. So with that in mind, we made recommendations to assess current resourcing and determine if there are ways to meet patients' psychiatric needs. More specifically, we recommended that Jail Health Services develop, document, and implement a plan to reduce psychiatric clinic wait times for patients in the general population at the downtown jail. This plan should include updates to their behavioral health staffing plan, a review and update of current standards for psychiatric clinic appointment wait times, and a process to track wait times against the standard for patients with both more and less severe needs. So with that, I will hand it off to Elise to round this out.
Great.
There it is.
So, I'm Elise Garvey with the King County Auditor's Office, and I'm going to talk a little bit about our other findings in the areas related to medication changes and medication provided at release. So I'll start with medication changes. Based on their prescribing guidelines, jail health providers sometimes change or discontinue patients' existing medications that were prescribed by a provider in the community before the patient was booked in the jail. And jail health can make these changes without first consulting the patient or the original prescriber. People we interviewed for the audit, including nurses, community advocates, and patients, told us that some of these changes can result in negative side effects. And as we noted with delays, they can also lead to negative health or behavioral issues. Some patients also said that they did not always receive notice about these changes beforehand, and the communication is not accessible for all patients, for example, those who have difficulty reading. So we're recommending that jail health more frequently review and update their prescribing guideline policies, incorporate a risk assessment, and incorporate perspectives from nurses, patients, and community advocates. We're also recommending that jail health update its procedures to more effectively and efficiently communicate medication changes to patients. And our last findings are about the medications that are provided to patients at the time of release from jail. And the purpose of this is to provide a supply that the patient can take until they are able to connect with a community provider and get either a new prescription or a refill. This is important because having a supply of medication sufficient to get to a provider in the community can help prevent worsening symptoms of their underlying conditions in the meantime and prevent withdrawal, overdose through self-medication, and death. In general, jail health's policy is to provide a 7-day supply of patient's medication at release when appropriate. Given the current wait times to see a community provider in the area, this amount is not always sufficient. And in 2023, we found that fewer than 20% of patients who were prescribed behavioral health medications received a supply at release. This might be partially because, aside from programs that focus on patients from some priority groups, such as those taking medications for substance use disorder, getting medications at release is up to the discretion of a provider or a nurse, or a proactive request from the patient. And multiple patients that we interviewed were not aware that they could request medications at release, but said they would have done so if they had understood the option. So we're recommending that jail health implement formal strategies to expand patient access to medications at release, including improving communication and developing more pathways that don't rely on the patients to have to proactively request the medications and advocate for themselves. Jail Health already has efforts underway to provide medications at release to more patients, which could be a good starting point to implement our recommendations. So to recap, Jail Health prioritizes stabilizing people who come into the jail with higher behavioral health needs. This is a reasonable approach, but leaves some gaps, such as long wait times for clinic appointments. Medication changes or discontinuations can result in negative side effects, and there are opportunities for improved communication with patients. And lastly, Jail Health does not currently provide a supply of medication at release to most patients. We want to thank you for inviting us to speak with the subcommittee today. As we mentioned earlier in the presentation, we have additional findings in our report, which are available on our website. And with that, we can take any questions.
Shall I just jump in? I raised my hand, but
Yeah, please.
thank you for presenting this. These issues are not, I mean, these issues are not new. Have been around for some time. I'm wondering if your audit had identified the barriers for the system, like for the jail system, why they were not giving them longer prescriptions or why they were not communicating. Can you speak a little bit more to maybe what the response was like, well, this is why this is happening?
Yeah, was there an area in particular that you were
Yeah, so why are they not releasing them with more than 7 days? What's the communication breakdown?
Great. Okay, so for the two issues there, for the communication breakdown, um, and the amount of the supply, part of it was the staff reported that their assessment of potential risks associated with the amount of medication that a person receives at release was part of their consideration for what the amount and the supply would be moving forward. And so part of their policy came from there. There are also exceptions to the policy. For example, folks who are being released directly into a program upon release may be eligible for a longer supply. Um, so those considerations were what went into the amount that they decided upon.
And I can speak to the communication piece. So sometimes in an audit, findings are very clear and obvious about, you know, why something is the way it is, and sometimes it's because resources have been focused elsewhere, and that's to some extent seemed to be the case. This was a system that was built over time, and they do have a communication system. It's a kite system that I think is pretty common in different jails. And the to some people's eyes it works well enough. And so when we started hearing from patients that maybe it isn't, that was something we wanted to bring to their attention and let them know that there was a problem that maybe they didn't know about. And so in this case it really just could have been not knowing about the problem, which was something that we were happy to be able to help like uncover and talk through with them.
I guess I'm next. A couple of questions that come out of our experience here. Did you gather data that we might find in the full report, or did you see data that the jail gathers that would track released detainees, looking at recidivism, whether they got a clinical appointment, whether it was beyond the 7 days of supply? Is there any way you can parse out those things, or things like release to the streets rather than stable or even temporary housing? And lastly, whether you could flag any racial disproportionalities in the provision of medication, the timeliness of a prescription or a clinical visit.
Yeah, so I can speak to that. We as for the racial disproportionalities, we did have data on this, and we did find that Black folks received medication. Received medication in a less timely manner, and so as Elise said, one of our recommendations was around that, and focused on getting jail health to look into those causes and understand why that might be happening. It is a complex system where racism is sort of embedded in from the beginning, and so we didn't have a clear solution in mind. We just asked jail health to go take a closer look given the data we had shared with them. So that was based on an analysis of their medication administration data. So that sort of the results of that analysis are in the report, which you can totally take a look at. And then the other point was to data on folks being released and what that looks like. Jail health does not have access to a really robust system of data on that. Once folks leave the system or leave the jail specifically, it's really hard for them to stay in contact with those folks. So we did not have a chance to sort of analyze something more, sort of full circle of, what does recidivism look like? Who's coming back to the jail? That data just wasn't available. And for our knowledge was hard for jail health to collect because they have tried to some extent.
Thank you.
Tuasa?
Thank you. So a couple things on the recommendations. So like, is there any comparison analysis between being inside the jail and outside the jail as far as having time or how much time it takes to get appointments for something like this? Because I know on the population level on the outside, just getting mental health help and getting services for even people with good insurance is sometimes, just getting the initial appointment is 30, 40 days out. So in comparison, is it really that different? And then also secondary to that, I was thinking as Stephen was talking, can people, like our disparities looked at as, can they refuse the services? Can they refuse to take the medication? Can they refuse the clinical? And is that calculated into the numbers to be assessed? If they're refusing the services, then so forth. I think that's a couple of the questions just off the start. Oh, and then I guess one third question, you talked about behavioral health staffing, but you opened up the audit report with the fact that sometimes they can't get to their clinical appointments because of a lack of correction staffing. And so is there a way to I see this a lot. They focus on their silo of one problem, which isn't enough behavioral health staffing, but it's also embedded in not enough correction staffing. And how are you partnering those two problems so that, if you're solving one, you're not solving the other, it's still a problem overall?
Okay, so I'll start with the first question, which I think was related to like the amount that folks might be released with and what kind of access they might have to appointments out in the community. Is that correct?
No, I was more looking at jail versus non-jail population and access to these services. You're looking at number of days, but it seems like those number of days are similar to people not involved in the incarceration or criminal justice system not having easy access because there's a lack of services for just the general public overall. Like by comparison to the general public versus in the jail, I mean, I know that I've tried to help family members to get, a counselor or a therapist, and we're 30, 45 days out before we can get a first appointment. So how is that in comparison to the overall population?
Understood. Okay. Yeah, so we don't have data on the wait time that folks might be experiencing in the community. Estimates when we talk to, for example, community organizations, the patients themselves, there is an acknowledgement that there are long wait times in the community, and the providers with jail health also discussed that the 30-day policy was intended to somewhat reflect community wait times as well. Another consideration that we included in the audit, though, is that jail health the downtown jail is an accredited facility with the national NCCHC. I'm gonna mess up the full title now. National Commission on Correctional Healthcare. And so there are standards within that relate to mental health care and wait times for appointments that are intended to ensure that folks are receiving care that they need while incarcerated. And so it was part of the reason why we didn't make a very specific recommendation for how much wait time should be reduced. But given the impact that we heard from the folks that we interviewed, including staff and concerns about folks being able to access care, that's where our recommendation was based off of. And then there were two additional questions. Basil, did you already have an answer ready?
Yeah. Prep time is an amazing thing. As for you were talking about the racial disparities and whether, somebody refusing medications played into that, right? Was that your second question?
Roundabout, like, can people just flat out refuse the care that is provided? And I don't know if it has an impact on racial, but could it, I guess?
Yeah. The short answer, yes, people can refuse medication or treatment however they like. And that does happen. We reviewed, paper administration forms, and there were plenty of people that refused or were not in their jail cell when the nurse stopped by. There are a number of reasons why someone might not get medication that was ordered. In the analysis we did, the for the racial disparities, we were looking at medication orders, so not the point of administration, but whether or not a provider had ordered a medication. So refusal would not impact those statistics, but absolutely could impact whether or not a patient actually received it. Something that came up in our audit was that jail health uses a paper administration system. Essentially, nurses are writing down what happened when they tried to give out the medications, which makes it very hard to analyze. So that was a recommendation we provided as well, was for them to transition to an electronic administration system so that they can do analyses on that front as well that aren't, reviewing hundreds of PDFs, which is, as you imagine, not super conducive to analyses. And then the last question, I think, was on correctional staff and that impact on the ability to provide services. And we found that it is siloed at King County as well. It's a tough problem to solve, and we did get leadership from jail health and DAJD, the Department of Adult and Juvenile Detention, the jail, essentially, in a room together a few times to talk about, their common problems and what, solving them might look like, or what resourcing might need to look like. But it is a complex problem that ultimately lies with the leadership of those departments to try and address, because there's no one solution that makes a lot of sense. It's all context dependent.
Thank you.
So I had a couple questions. What is the process for people in the jail to be informed of the opportunity to request medication upon release? Is there some kind of protocol, or you said some of the inmates you talked with they would have requested it, but they weren't aware that that was an option?
Yeah. So I don't believe, Basil, that we saw like a written procedure for this. Our understanding of the process was that folks might be told, for example, during an appointment with a provider, they might be told by nurses. Patients that we interviewed who were aware of the process reported to us pretty varying methods for how they knew. Some of them knew from a previous stay at the jail. Some knew because hospital staff had told them. I think when they were receiving treatment outside of the jail. So that indicated to us that, if there was a process kind of in place, that it wasn't reaching folks in the way that might have been intended. So that's why we included communication as part of our recommendation in that area.
And I wondered, could you talk a little bit more about sort of wait times and for people with less acute, say, psychiatric conditions? And because you mentioned that in the report that those people were not did not receive medication on a timely basis as well. But what were there any differences between those of less acute and more acute?
Yeah. So I think, like as we were discussing in the first part of the presentation, folks who are receiving psychiatric medication or substance use medication might be housed in psychiatric housing. So there are kind of varying levels of psychiatric housing where jail health services has a stated cadence at which they see those folks, and so they're seeing a provider every few days. And so those opportunities those appointments create opportunities where they're being assessed, and a provider might be able to recognize a need for a medication or a need to change a medication, or something along those lines. For folks in general population who are not assessed to have as high of a need to be in those on those psychiatric floors, Jail Health has a policy of when an appointment is needed to set it up at a 30-day interval. And so that person is then added to their system to see somebody after that period of time, depending on the capacity of Jail Health to be able to provide that appointment. And so if there's less capacity, for example, somebody might not be seen for a longer period of time, which is what we saw happening in the data from 2023.
Okay. Bertie?
Yes, I was wondering if there was any systematic process for inmates who are booked into the jail that are currently taking psychiatric medications to be prioritized to continue on them, or do they just have no plan to continue current meds, and then they fall off and maybe develop issues or whatever?
Yeah. So there is a process for this. They call it medication verification. So when somebody is booked into the jail, a nurse will do an intake assessment and talk with the patient and ask about any medications they take, any health conditions, all that sort of stuff, and just do a sort of a full assessment to the best they can. And when they receive when there's a patient that says, I am on this medication, the nurse will ask where their pharmacy is, and they'll go ahead and call the pharmacy, not during the appointment, but right after, essentially, or in the next day or two, and they'll try and verify the medication with the pharmacy. And so if they can verify it, then the medication will be, for the most part, just like continued. Unless it falls outside of these prescribing guidelines, in which case they might be changed anyways. But that's sort of the process. We did hear issues with the VA, for example, being a difficult place to get a verification from, because there's some paperwork hoops that they have to jump through, or if a pharmacy is closed and somebody comes in on Friday evening, not being able to verify until Monday. So there are definitely issues with that process, but there is sort of a fast track to keep people on the medications they're on.
And I'll also note that they have like a categorization system for medications, where some of them, if they are more urgent, staff there can consult with one another on whether the person should be started sooner than verification. And also another process that they discussed with us that can help speed things up is if the patient's records are in the electronic medical record, which is the EPIC system. So for example, if a patient is booked into the jail and they've received a medication recently and it's in the system that the jail health uses for their electronic medical record, it's easier for them to see if that medication was prescribed recently.
Does that mean that they're in an outside facility that uses EPIC, like a hospital or a private doc's office system using EPIC, or does it mean that they've been incarcerated previously on the same med when you say within EPIC?
Both.
Both. So it does have access to outside EPIC records.
Correct.
Thank you.
Okay, any other questions? Seeing none, well, thank you so much, Lise and Basil. This was extremely informative, a very thorough report and analysis of some very complex issues. So thank you so much for attending our meeting and presenting your audit.
Thank you so much for having us. And we're
And
available. Our contact information is available on the presentation and the report. You can reach out to us at any time.
And please wish Kimber Walthmusen happy birthday from me.
Well,
Okay. Before we move on, I just wanted to say that I was thinking as kind of the facilitator of the diversion and reentry work group that we would take this report or portions of it and see how Whatcom County Jail compares on a few metrics with some of the things they found in this report. And I've talked to both Tank Tanksley, and we would work with Caleb and maybe Lifeline Connections. And so that's something we might start up over the next month. And there's so much in that report that we wouldn't want to take on everything, but I think there's some select issues that would be beneficial for us to take a look. And I encourage you, there is a link in your packet to the report if you want to look at it. And they do have a fair analysis of some of the racial disparities they found in terms of time to get prescriptions ordered and other things. So, okay. With that, I think I'll turn it over to Dan Hamill, who's going to give us an update on ART funding.
Okay, I'll be very brief on this one. I want to make sure that we provide time for Detective Thompson to provide a JPOP report for the jail planning. So I just want to report out that the City Council at the last meeting approved a $375,000 allocation for the alternate response team. That's over the course of the next 18 months. I don't know if Melora, if you have any other anything to add from the county side, but we are the city is very supportive of this program, and it's been in operation for a few years now. I don't know, Melora, do you have anything to add to that?
Yeah, I would just add that the alternative response team, our current service status is that we have 5 staff and 1 supervisor. We're able to provide services Monday through Friday, 8 to 6 p.m. That includes an embedded staff at Whatcom 911. And we regularly, from both Bellingham Police and Whatcom, are asked to expand hours. And so the current funding status that we have is positive in that we are not going to have to reduce any services, and we will be able to maintain that Monday through Friday. The full cost of the program is over $1 million a year for that current status. And so the city will be contributing, the county matches that. And then we were very lucky to secure 2 years of funding through the legislature at just shy of under $600,000 a year. So what's really exciting about this is that the state has chosen to continue to fund this. We are one of 2 alternative response teams in the state. It is Whatcom County and Seattle are the only 2. And so we're honored to do that work and feel really supported by city, county, and the state, and we'll be able to maintain services planned for the next 2 years. We have secured another funding source through the Behavioral Health Administrative Services Organization, the BHASO, to expand by 1 staff. Unfortunately, 1 staff is not going to help us clearly expand hours, but once we're able to post and hire that 6th response, alternative response team staff, then we will be looking at what that expansion looks like. So more to come. But yeah, there's 4 very secure revenue sources for this program. And so we're really excited to see its stability and moving forward.
Thanks, Melora. Any questions from the group regarding the alternate response team? Okay, I don't see any hands raised. Okay, I want to keep us moving along here. We're getting a little bit short on time, but I think I don't have the agenda in front of me, but I think the next item up is the JPOP update from Detective Thompson from Linden PD.
Hi, thanks. Yeah, so I wasn't exactly certain what you want from for this presentation, so I'm just going to highlight some of the things that we've done. We've been in, we were established last year for the tax initiative and the new jail initiative. So, and a part of our is oversight and planning of IPRTF and the jail and the behavioral center and the 15-point implementation plan. So we had our first meeting in October, and since then we just recently completed our yearly implementation plan evaluation, and also conducted or completed a performance measurement plan. So it kind of, we had an outside source, Julia, came in and implemented all the things and all the things that we've been doing, and then gave us a roadmap moving forward for the great things that we've started and how to continue working on those 15 points of the implementation plan. And so that was presented at our last meeting briefly, and that will be coming out. And then, of course, another big arm of our requirement for JPOP is communication. We had a great meeting at the last meeting. We met Riley for the county executive's office, who's going to be kind of our public outreach communication specialist, and we're coming up with different communication opportunities for where are people at, where can we reach them, and how can we communicate what we are doing, what we have done, what we'd like to see being done in the future, and also to encourage input from the community on continuing forward with this plan. Another thing that came out, and I just got to finalize, so I don't know if everybody here, I recognize several of you attend different committee meetings along with this, from Index to IPRTF. And so I want to be conscientious of your time. Some of this may be, I don't want to repeat things that you've heard in other committee meetings. And so, but we did just get we did a survey at the jail at the jail here in Whatcom County, because though we have been looking throughout different jails throughout the nation of different programs they've been implementing, and we're taking a lot of those ideas in. We need it very specific to Whatcom County, because in our own community we have similarities to other communities, but we are our own special place. And so they just sent out the finalization for the jail survey and the facilities goal. So if you do not have that or have not seen that, they have not yet put it onto the website, because they're trying to figure out where to exactly seed it. Would it be under JPEP or IPRTF? But it is available, and we can send it to you if you would like to read the report in its entirety. It is 89 pages long, so I'm not going to go over the entire report with you, but there were some key takeaways about specifically behavioral health issues and housing insecurities are two prevalent concerns among people in the jail. There was also many of the inmates have been in the jail system and in and out of the jail system multiple times. So the recidivism aspect, which is something that we are also looking into, or we're trying to prevent and disrupt. And then also involvement with the criminal justice system and the impacts on their education, work, familial relationships, and housing, and how those hurdles impact their community reentry. So if you would like to have that entire report, it's a great report. And again, like similar to the King County Audit, therapeutic interventions within the jail, and then treatment for that with the jail, and then continuing that outside the jail. Of course, I think that coalesces with the audit report that we just received earlier in this. And then some input on the design elements for the new jail, specifically areas within the jail for some of the things that they've identified as needing therapeutic services and places for that. And obviously our current facility is very limited in having any open communities or spaces where they can meet as a group easily. And then, of course, outside lighting, and some of the design elements that we have been discussing. So, as some of you know, the county has hired the, I'm going to now blank on the name, but basically the owner representative. And so they are also, as part of that, we're working with them, hopefully their communication plan for where they are in hiring a contract services, and, or, their job is to hire contractors, but also to have communication plan out to the community. So last I heard, they're getting close on having that communication plan ready. So we're hoping to get that information soon as well. So I guess if you have any other questions about JPOP, but I do have a question for you guys. And I was talking with Crossroads consultant. Many of you know Marty and Holly, who assist in these meetings. One of the feedback things that we have been, as we look forward to the next year for our committee and how can we help, one of the questions we have for the Behavioral Health Committee is there something from our committee that we can help you guys with? So that we make our plan for this coming year on how we can be best utilized, how we are not doing overlapping work among our committees, but is there something that you think that falls under something we would be capable of doing that would help your committee be more effective?
Thanks, Detective. Committee, anyone want to respond to that question? Stephen, go ahead.
Actually, it's not a response to Tasha's last question, but just in regard to the recent final report on the jail survey. I think there are people on this screen who aren't on Marty's and Holly's mailing list. And so Tasha, I wonder if it would be valuable to send that to Jill and Jill out to the committee, because, for instance, Brian mentioned his diversion and reentry work group, which I think could benefit from that information as well. So just making sure all the communication gets to all the relevant parties.
Perfect. I will send that to Jill shortly.
There's no other respondents. I would say, Tasha, that there are 3 subcommittees within this committee that are working on, there's one that's working on the Division Street campus to provide recommendations to the broader task force on creating a behavioral health campus. And there's also a reentry and diversion committee that's within this group as well, that's actively meeting. And then there's a data committee that's as well. So there's 3 different committees that are performing work here and try and make recommendations. I think just having, and I hear you when it comes to not wanting to not just overlap, but also be at cross purposes when it comes to any work that's being done in the behavioral health realm. So I would just say I think a broader understanding of what the intention of a behavioral care facility co-located at La Bounty, what that's looking like, just getting an update on that periodically would be helpful. And I'll stop there. Any other questions?
Well, I believe the task force is going to create a advisory committee for the behavioral care facility at some point.
Yeah, I guess what I'm saying is that what Tasha said in terms of, like, you see a lot of the same faces in these different meetings. And I think just providing clarity as to who is doing exactly what would be helpful, because we don't want to overlap, and we have a limited stream of funding. The city has committed to provide, after the down payment on the capital part of the jail facility, the city has committed to providing substantial resources for behavioral health for the facility, not just in capital, but ongoing in operations. It would just be helpful to have some what I would refer to as like lane definition. Like what lane are we in? What lane is the behavioral health committee in? What lane is the JPOP committee in when it comes to the behavioral health aspects of the construction and operations? That's all. I'm asking for clarity. And a lot of the folks on this call, well, everyone on this call has another job that they're trying to do. They come here, they're trying to be as you know, trying to contribute as much as possible. I want to make sure everything is very clear as we move forward. That's really it, just clarity.
Yeah, and my observation is JPOP and the overall task force steering committee, it just seems like, are those, to Dan's point about what lane are we in? I've never really understood. It seems like there's some overlap between the two groups. I could be missing something, but
Oh no, Brian, we've had that discussion as co-chairs in meeting planning. Is I go to the steering committees and I hear a lot of the same information that we then kind of retell at the JPOP committee, and I've made it clear to Holly and Marty that I would like to delineate. Like we have 2-hour monthly meetings. Obviously, we're going to be talking about the oversight part, like bringing in the information from each of the committees and sharing it in one space, such as the oversight, but also, we were talking about focusing more on communications to the public, taking in information and being more proactive in expanding our reach for, the community at large, and making sure we are bringing all the voices to the table that need to be brought to the table. Because some of the pushback and I think every committee feels this and every government official feels this, is that people have a nugget of a little bit of information and then they grow what they think from that. And so how do we expand our reach just for general information to the public, and so that maybe we avoid some of those potholes of people not having all the information. So we've been having good discussions in kind of a strategic planning moving forward for JPOP, on really identifying what our overall role, because some of the things that we're seeing are long-term projects. So monthly meetings are not necessarily always going to have to talk about every point in the plan, because it's a 6-month project. So in 6 months, we can come back around and see where we're at, but we don't have to talk about it every month. So in the months that we are less busy, or how can we continue to support that goal and support your different committees? That's kind of what we're here to do as well. And so our focus, I think we're going to really look at, because of what our purpose listed in the website and in our I'm not necessarily bylaws, but it is community outreach. So we really want to focus on how can we do that better to highlight all the work that all these committees are doing individually. So we can break down some of those silos.
Okay, Melora?
Yeah, I would just add, I really appreciate this conversation. And I think that there's, a plethora of advisory committees across the county structure. And I think most task forces, advisory committees, subcommittees all kind of struggle to be like, what is our role and what are we doing? And I would just say that I think the county has been trying to put out some quarterly reports that's trying to compile all of the information in one place. So, the Whatcom County Justice Implementation Plan is putting out a quarterly report. The IPRTF just put out an annual report. There's a lot of synthesized information that I think would be helpful for subcommittees to be like, here is where that body of information sits, and then is there any updates within that? Grabbing it from lots of different sources or different subcommittees, I think creates some confusion and, like Tasha's saying, gaps in people's knowledge. And so I just wonder if there's a way to say, here are, and these reports actually take a lot of staff time to prepare. And so I just want to make sure that they're being utilized in the way that I think we as staff were hoping that they would be.
Thanks, Laura. Yeah, I agree. I think there's a lot of information flowing around here, and you know, all these groups are very well intended, and they want to, you know, make sure that we're doing it right. You know, and I don't know. This is absolutely the biggest capital project that the county has embarked on ever. And so we want to make sure that we get all the pieces done properly. And I mean, I'm kind of just speaking for the group here, but I think that, you know, we want to make sure that we contribute recommendations that are going to be the highest and best value for what the county and the city and small cities are spending. So, okay. Other questions or comments from the group? We are at 10:07 right now. I don't have the agenda in front of me. Jill, do you want to throw it back up on the screen real quick and just kind of see where we're going here?
Well, we're going to go to the data work group
Okay.
recommendation.
Yeah, Brian, go ahead. Yeah, go take it from here.
Yeah, no. So I believe not sure who's presenting this, but is this Bertie and others? Yeah, I'll turn it over to you, and they're going to talk about their work group recommendation, the data work group recommendations related to the Village Reach report.
Is that a Dean and Bertie report?
Well, why don't I just take the lead and then I'll turn it over to Dean, and perhaps Jill, if you could put up on the screen our data subgroup recommendations for people to review. So just briefly, let me set the stage. As you recall, there is a data subgroup that we are responsive as a subgroup to both behavioral health and legal injustice. And our charge has been, among other things, to provide support for the review and implementation of the Village Reach recommendations that have just been finalized. So we are bringing our recommendations after synthesizing and discussing the Village Reach 6-month project to this committee for discussion and hopefully some approval, because the timeline is that Village Reach completed its work and presented its final detailed recommendations on June 30th. Our data subgroup met July 3rd. The Legal and Justice Committee met very shortly after that, and Behavioral Health meets today, and then the full task force meets the end of this month and doesn't meet again until late in September. So the concern of the data work group was to make sure that the recommendations that came out of the 6-month contract are looked at well and brought forward in a timely manner for the full task force to weigh in on and for the county to react to and come up with an implementation plan for it. So with that, Dean, if you're willing to take the lead, Cedric and Amy Hockenberry are both on our task force and are present in this meeting too. Dean and I were at the Legal and Justice Committee. So Dean, do you want to take it away at this point?
Sure. So of the recommendations that Village Reach produced at the end of its report that basically created a framework for measurement of all the various elements and levels of the Justice Project. The recommendations they brought forward were in two categories. One was short-term, 6 to 12 months, and the other was 12 months and beyond, looking out perhaps as far as 3 years. The very first recommendation among the four short-term ones was to establish a position within the county that could now take on the task of implementing or guiding the implementation of the measurement and evaluation plan that Village Reach presented. And so all we're doing in our recommendations are simply to emphasize that particular recommendation and a couple of other ones that follow on from that, including development of an infrastructure for cross-system data integration. All of the wishes and wants that have been discussed over the last decade, really, around measurement and evaluation have presumed that we somehow have all of the data at our fingertips and the resources necessary to organize those data into consumable measures that can be looked at on a dashboard or in some kinds of reports. The reality is that's not the case, and for many reasons. And so because this project, the overall justice project, is so complex, involving so many different players, departments, organizations, each of whom have a stake in knowing whether what they're trying to do is actually happening and making a difference. It needs the guidance of a position that can really project manage all of the data collection and calculation and reporting activities that need to go on. So I think what we're saying is we strongly recommend, first of all, that position being created and funded by the county. The Legal Justice Committee looked at these recommendations, and if you want to scroll down, Jill, I think the third one is doing some initial near-term reporting. There are some data available that we could use to at least begin to report particular measures around jail utilization and so forth. But again, the Legal Justice Committee, because it didn't have a lot of time to really delve into and discuss the recommendations that we brought to them on short notice, they did vote to approve the first of these three in our recommendations, that is the position being created and funded. So that's where we are today. And I think we're ready as a data work group to try to answer any questions you may have, both about our recommendations and sort of the overall thrust of the Village Reach report.
If I could just chime in quickly, the only thing I would add is the biggest concern that came out of Legal and Justice was the feeling from those on that committee that in their individual departments, there was not a penny, a 10 minutes of staff time to share with any data project. People are really strapped. And so our emphasis was that our recommendations involved the county looking at the scope of work, hiring somebody to be the project manager, and then developing a budget and a plan for coming up with the resources needed to do this, as opposed to the expectation that somehow it would be patched together in our meager resource system at the present.
Okay, committee, Tasha, I see your hand up.
I guess I don't know that you guys have discussed specific programs for doing this, but recently Bellingham Police hosted a training for all the law enforcement agencies regarding this particular, our information sharing is, we don't share between agencies. And this has been an ongoing concern, even though the county uses its own reporting system, but a lot of the others, Bellingham and smaller cities, use the same long arm reporting system, but they don't communicate with each other. So, and obviously we know that people who commit crimes don't stay within the boundaries of certain jurisdictions. And so Christine Paulson, who's the tech gal for Bellingham Police, brought in this program. I think it's called Peregrine or Peregrine. I wasn't able to make the meeting, but I sent my partner detective. But one of the greatest things, it's kind of an overarching that connects the systems, and you can set it up to do whatever you want it to do. Like he described that one police agency has a link for each call has a number for threat assessment for PTSD for how much of a stressor of a call is, so that like for us, like a SID, a sudden infant death call, is going to get a high rating on a potential for trauma to the officer who handles it. And so, and then it pulls each officer, like when your officer reaches, 80 points or whatever number, as this officer's now, there's no time frame, has now responded to 8+ calls of 10s for trauma. They got to get pulled and go and talk to the peer support or wellness. It's mandatory. It's not optional kind of thing to help. So the program they were describing, you can set it up to do whatever you want. And it also will coordinate with the court system for how they track our reports going into the court system. They said, and it's all obviously because it's our criminal justice system, it fits in the criteria for all the requirements for privacy, et cetera, for the laws on that. So I think it could potentially be something that could even expand out. So I don't know if you've looked at different programs or companies that provide these type of programs that could unite into one space all the different programs, which is, I know, one of the concerns and things that we've been discussing in all of our committees is our lack of ability to communicate across our programs. So that would be something I was going to bring to the JPOP on whether or not we could have a program, or I don't know if it's more appropriate in your group to have maybe that particular, I could connect you with Christine to bring in this guy who kind of gave a 2-hour presentation on what their program could do, to see if it's something that we could incorporate in, even with mental health and all the alternative services to coordinate for that. But I think that's something that as a group we should be looking at as well.
Ver, do you want to respond to that?
Sure. I think that gets back to our overall recommendation. The entire performance measurement of this implementation plan involves so many complex agencies, and there are a number of programs like that do significant pieces of it. But what we need is the overarching picture and somebody who is managing all those pieces and bringing it together in a coordinated way. And so it's a perfect example of why the data subcommittee believes so strongly that we need an overarching, essentially a project manager who is going to be responsible for shepherding this very complex animal with all moving parts forward.
Dean, I think you want to respond to that as well.
Yeah, I think the experience in the healthcare world is illustrative of the challenges that we would face in trying to really bring data together from multiple systems. There have been many kinds of software applications that have been developed and promoted by vendors in the healthcare industry that purport to solve those kinds of problems at each individual organization's level. The federal government's mandate years ago was that systems begin to be designed to be interoperable with other systems. And so I think that the same challenge exists in the legal and justice realm, and particularly as it tries to interact with healthcare and behavioral health. I would certainly be interested in knowing more about that, but I guess I've just been in enough presentations of software from vendors, saying this will solve all of your problems, when it still leaves the question of how do organizations agree conceptually and in a policy standpoint to agree to share data across systems. And even as one of the recommendations from Village Reach says, simply start by agreeing on definitions of each field and what the various elements might be. That's a huge hurdle in and of itself, and we've got a long way to go in that regard.
Thanks, Dean. Hey, Brian, before I go to you, Amy, I saw your hand up. Did you want to add to that?
No, I'll wait. I'll make a comment after maybe Ryan's question.
Okay. All right. Brian, go ahead.
Well, I certainly support the funding to identify like a project manager, I assume in the executive's office somewhere. But I'm also wondering about additional funding for individual departments to be able to staff this effort. I mean, that's got to be a major concern, as well. Especially when you're talking about data integration. I mean, this is a huge undertaking. I see Melora shaking her
Mhm.
yes. And I just wanted to point out that the Village Reach report did talk about updating the SIM, which I guess was last done in 2022. I mean, and just the staff time required I'm quoting here from their report, facilitate a multi-agency workshop that built on the county's initial SIM table and the evaluation design work completed to date. I mean, there's another example of
Mhm.
how do people that are already,
Mhm.
so pressed to fulfill their responsibilities, apart from anything related to the new jail. I mean, where do those resources come from?
Mhm.
I mean, I'm preaching to the choir here, obviously, but it is a very legitimate concern.
Mhm.
Amy Hockenberry, go ahead.
Yeah, I just want to build off of that and to maybe reiterate a little bit where Dean and Bertie were going. And I just want to acknowledge too, there's two very large buckets here. And one of them is the modernization and interoperability of our technology. And that alone is a big undertaking, as Brian was just mentioning. And then there's the reporting, the analysis and the reporting. And then that's also a large body of work. So I think, I've heard it a couple of times throughout this morning or this meeting with JPOP, with communication and transparency and being able to communicate, that's a huge portion of this evaluation plan as well. So I just like to see that data and the investment in our infrastructure so that we can actually see if these 15 strategies are making the impact they're intended to make in 5 to 10 years from now, as opposed to in 5 to 7 years or 10 years from now being like, oh, we didn't invest in the infrastructure of our data. And now we're scrambling to figure out, did we actually make an impact? So as we move forward, I'd just like to see that the prioritization and focus on data and our infrastructure for that is equally at the table with along with the 15 strategies that we're trying to implement. So I don't know, getting on my soapbox, so I'll stop now. But just
No,
reiterate the importance of investment and prioritization. So, and there's opportunity to make some headway concurrently, as pointed out in the evaluation plan.
anyone from data or JPOP want to respond to that? That's a good point. Go ahead, Bertie.
My
Or
response, putting on my public hat and the colleagues that I work with, is that I think it would be very helpful for us to recommend to the county that they name it and say, we need a major investment in order to really do performance evaluation of this. And they name it, name the need for the significant investment, look for funding sources, and put it out there so that we're all on the same page and we're not creating false expectations that we're going to be able to tweak this and that and put up a meaningful dashboard, for example. And so my hope is that from Julia's report and the Village Reach, the IPRTF can throw its weight behind the significance of this project and the need to develop a plan, a project manager, and resources to do it well. That's my soapbox, so I'll climb off as well.
thanks, Bertie. Hey, Stephen, real quick before I go to you, Tasha, just as a JPOP rep, do you want to just maybe respond or you have thoughts?
Well, yeah, I mean, Amy, I concur. We've had those same discussions on JPOP of just pulling the numbers, but then recognizing the vastness and the barriers to those numbers. But the need to be transparent is huge for the community at large. And so, you know, that's why I think we're also delving into, and then also, and I've had this conversation with Bertie, what numbers, you know, are we trying to capture every single person at the far ends, or were they capturing the solid people in the middle that you could truly get measurements from? Do we have to look back in the past to know what our numbers were before we started this implementation plan and then moving forward? So even delineating all those things. Thank you.
Dan, I just had a quick question. Bertie, do you want a motion from this committee to approve
Yes.
recommendation?
Yes, we would. Because of the structure, we would hope that this committee would approve at least item number 1 to establish a dedicated position in operation for the plan. And anything further, because we would like to take it with the endorsement of our parent subcommittees, which is this and legal and justice, to IPRTF. The executive has said, we want you to advise us on policy, you being the IPRTF. So we feel this is an opportunity to do that.
Jill, do we have a quorum?
Yes, we do.
Okay. So hold on. We've got so I'm gonna need a motioner, but I've got 2 hands up real quick. If one of you is wanting to make a motion, then great. If not, I need a motioner. And just
I'll make a motion to approve number 1 of the the recommendations.
Okay, is there a second?
Second.
Steven's a second. Okay, further discussion to the motion? Okay, seeing none, all those in favor signify by saying aye. Raise your virtual hand. Be the easiest, or okay, let's see. 1, 2, 3, 4, 5, 6, 7, 8. We've got 8 yeses. Any opposed? Okay, lower your hands. Okay. All right, motion carries. And I saw 2 hands up before the motion. I want to address those, and I want to also let folks know that we are almost out of time here, and we do need to provide for public comment. There's a few. I think there's some people still in the room. I didn't check attendees in the last 10 minutes, but Arlene and Stephen had their hands up. Arlene, go ahead. You had your hand up for a while. You're muted, Arlene.
It seems to me that we've been talking about tools that this project needs. And I think that's very important. But even before the tools, such as data, we promised this community that we were going to do 2 things: the jail and behavioral health. Okay, we are already postponing one of the big parts of behavioral health till next year, and therefore possibly acing it out, in which case we would be breaking our promise to this community. We promised that we would address it. So we are addressing it in the jail, but not in the community. And I'm talking about the crisis clinic. Yeah. So I'm going to keep reminding you that that matters. And that if we don't do it, we are not doing our responsibilities.
Okay. Thanks, Arlene. I appreciate your diligence on that. Stephen, did you want to make a comment or question, or?
No, in the interest of time, I'll pass, Dan. Thank you.
Okay. Okay, so we are at 10:30. I want to respect everyone's time. I know that you've got other things that you're doing today. Jill, do we have any, and thanks for the conversation today. This is really, it's a lot going on here. And we've got more ground to cover. Jill, are there any folks from the public that want to speak to the committee?
Looks like we have a number of attendees today. We have one person in our conference room. Would you like to speak to the committee? You can unmute if you'd like. No? Okay, thank you. And we have 4 attendees attending virtually today. If any of you would like to speak to the committee, please virtually raise your hand now. And no hands are raised.
Okay, I see no hands. All right, folks, thanks for coming today. It's 10:31, so I'm a minute over budget, but I did my best to get you out of here on time. Have a good rest of your day, and we will talk soon. And this meeting is concluded. Thanks. We're adjourned.